at this a little bit. Thank you. Kind of went a little bit out of order here. I started off by saying follow this sheet and follow this sheet, follow this sheet. So we actually went to history taking first before primary. Well, we didn't follow the sheet. So anyhow, my dad used to say, "Do what I do," or as I say, or whatever that was. So the primary assessment. So we have 6 components of that on this skill sheet. And because I like to be figured out, I like to move around, I like to interact with you guys, we may not put this slide. Primary assessment. So on your skill sheet, the first thing it says on primary assessment is verbalize a general impression. So when you make, I know your face from work, but I don't know your name. So Michelle. So Michelle, we form a general impression on a patient. What's a couple things you're looking for? So you walk in the room and our patients see the skeleton, we'll say our patient's over there. So primary or general impression. What are a couple things? Okay. All right. Okay. So skin tone, skin color, work of breathing, position, all that's really good. Anything else you look for? Synchronistic based on that stuff or other stuff? Okay. You walk in the room. What's that? Okay. What's that?
Do they even look at you?
Do they even look at you? Do they even acknowledge your presence? You walk in.
What about the ones you've got? The ones that you're on there for they're having difficulty breathing, but you show up and they cigarette.
Exactly. Yeah. Okay. Yeah. So our general impression. It's kind of that through the door. What do we see? That's sick or not sick? Do they look sick? And what determines sickness or not? Obviously, the respiratory smoking a cigarette. Probably. I know what my brain does. It goes up. Yeah. But again, the other one, the one before break that I talked about, the 26-year-old male that ended up coding on us. His presentation was, I can see it to this day. There's a couch. Walk in, apartment. Couch is the back of the couch is facing us. He's wearing athletic-style shorts, like basketball shorts, I'll say. He's a bigger guy, probably 6'2" or 3", probably 230, 240 maybe. Not a fat guy, but not a super fit person either. But so he's no shirt, just athletic shorts. He is on his knees like this against the back of the couch, and his skin is mottled blue in appearance. Sick or not sick? He doesn't acknowledge us when we walk in at all. So all the things you guys have said, that you do when you go walk through the room, yeah, definitely. He was definitely sick. To the point where it was like we didn't do any interventions or anything in the apartment. It was load, code, everything. But anyhow, so yeah, definitely sick. The patient I had last night will walk in and he's pale in color and shivering. Okay, sick, right? Obviously sick. The 55-year-old male with chest pain, he's got the Levine sign, which gets over the heart, and he's sweating profusely. Okay, obviously sick. So yeah, general impression of the patient. What they look like, and the big one there too is if they acknowledge you. If you have someone that looks sick and they're not acknowledging you, they're not tracking you or looking at you as you walk in, to me that's a real sign of a sick patient. And then the next thing it says on the sheet is determines the responsiveness, the level of consciousness. So this is where we use that first acronym, and I think there's some slides here on it. I don't want to totally just get away from this. These are a whole bunch of text on what the PowerPoint says for general impression. And I don't want to just read this to you. That's why I kind of get away from this. I feel like you guys are all probably made it through school and can read. So, but some things you guys all talked about. We didn't talk about this one, but isn't this a big one? Environment. Now we're talking medical patients. So let's forget about, I guess we could be outside, but let's not think about car wrecks or things like that, but just the medical patient. The environment. This is one of those biases I think that we all have a tendency to make. When you walk in that really porterish, dirty, smells like cigarette smoke apartment, and the person doesn't appear sick, don't we all kind of turn our brain, really? You know, it's natural. We all kind of do that. That's from being on so many of those. Then you go out to Legacy Ridge and Liberty Lake, and the house is immaculate, and you walk in and the guy looks ill, okay? You don't get the impression that he's calling 911 every day, right? And that's the other part of the environment. That same address. I know for like those of you that work at AMR, it's a little different because you're all over the county. But for me at 1121 South Evergreen, which is my home, we go to certain addresses, 222 South Evergreen, 1301, all these different ones. We looked up, we have one patient, we've been on 47 times in the last about a year. 47, yeah. So try not to let that be your bias, but I know it does. So in the environment, what's it look like? Patient's posture and overall look. So I talked about my tripoding patient, if you want to call that a tripod position. The one last night too, the curled up one, so obviously looks sick. And then their chief complaint. We're dispatched for difficulty breathing, like the guy from the city here says. We go to difficulty breathing, and they're smoking a cigarette when we get there. So chief complaint and your instincts going hand in hand there. All right, patient looks dead. Quick evaluation, responsiveness and breathing. How are you going to check their responsiveness? Sternal rub, okay. Maybe a little shake and shout. Feel for pulse. If absent, begin chest compressions immediately. Where are you feeling for that pulse? You're going to go for that radial? Carotid. There we go. Okay, they show signs in life. We're going to go to our standard primary assessment, or ABCs. We're going to determine right away, and this is all through the door. We're determining if it's a medical or a trauma problem which has caused this. Sometimes it's not readily apparent. My preceptor used to gave me this scenario more than once. The one time he set it up in our station, he put an actual step ladder with a light bulb gone, and then he took the mannequin and had it laying there. And he said, "You have an unresponsive patient. Basically go." So, okay, is that medical or trauma? And at the end of the scenario, I asked him, I said, "So what was going wrong with this patient?" "I don't know." I said, "Did he fall off the ladder?" "I don't know, maybe." But what he did is he gave me all normal vital signs. We had an unresponsive patient. So but what it did, it made you go through everything. Did he fall off the ladder? So do we need to consider C-spine? Probably. We don't know. Unless someone's standing right there and said, "No, he was getting ready to get on the ladder and he collapsed," whatever. But so you don't know. So yeah, you had to consider C-spine, and you basically had to do everything. You do a full trauma head to toe. You had to do everything. It's a really good scenario. I'm back as you guys get closer to being done, which is spring. May 15th. You may see that scenario from me if you come back. More serious the condition, the quieter the patient will be. Most cases, look, listen, and smell the environment. Okay, does it smell like cigarette smoke, or does it smell? I don't know how to put this. Cat too, or does it smell like GI bleed, or does it smell like UTI? Some of that. Which some places you go into, it smells like that in the hallways, so it's hard to determine. You go into the gardens, and okay, standard precautions with every patient. So, what are our standard precautions? BSI scene safe. So gloves and glasses, right? That's what we're supposed to have: gloves and glasses with every patient. What else? What else might we want? A gown. What's that? A face mask, maybe. You guys carry one in your pocket? I don't. Should I? Probably. I remember being bent over this patient, talking to him, and finding out that they had bacterial meningitis or something, and then pretty soon someone dangles the mask over my ear. Oh, that's nice now, But yeah, make sure you do that. I saw some lack of that last night with our critical patient. We had multiple people, whether it was in on scene or in the hospital that didn't have even gloves on. Identify yourself and establish rapport. Okay, very important. This goes back to the last segment when I said one of the best things we can do is, you know, ask them the right questions and really communicate with our patients. Try to establish a rapport. Reassure, listen to them. Don't trivialize their complaints. And this is hard to do when you've seen them 47 times in the last year. It's hard to, every time you show up, to give them that same level of respect and all that. Support their patients psychologically and physiologically. Okay, so this is just telling you, going down on your skill sheet, if you have this one, this is on that, pretty much that very top on the scene size up. Mechanism of injury significant or patient unresponsive, manually stabilize patient's head and neck. So we should do that unless we know that the patient isn't unresponsive from a fall. So the laying on the floor unresponsive, we may want to ask a bystander or something, you know, kind of what happened or how they get down here, or did you see them fall? If not, we probably should be taking C-spine. I know at times we don't have enough people to do that because you're working. A true critical patient probably takes, what would you say, how many people to manage a true ALS patient? At least, yeah. You can get a lot done with your 3-person crew, but really you probably need number 4 and 5. Now the BLS patient, sometimes number 4 and 5 can get in the way, right? It's like too many people. So there we are, manually stabilizing the head and neck. For the little guys, make sure we get a towel under there to align, get all this aligned. Mental status. So our baseline mental status is crucial, and really our baseline everything is crucial. When we get into talking about vital signs, we're pretty notorious for getting one set of vital signs. And a lot of times it's because we get one set, our transport shows up, and then they'll get another set, hopefully. And then because I think of our short transport times in and around the county, you know, 10 minutes, 15 minutes, maybe we get a third set of vital signs. But does one set of vital signs really do anything for us? Not really. What's that? They are, but I would hope if you took my vital signs right now, my blood pressure is going to be almost what would be considered hypotensive. It's going to be right around 100. My heart rate's going to be about 60. So, but those are numbers that, by numbers, could be bad, right? Now, if they stay 60, 60, 60, that's one thing. But if it's 60 and it continues to drop, that's another thing. Or if they're climbing. So we want to see trends. Same with our mental status. Medical situations that cause altered levels of responsiveness. It says stroke patients. We get diagnosed or dispatched to lots of things that are called strokes. But what else causes that patient to be altered?
UTI, diabetes.
What's that?
UTI, diabetes.
Yeah, UTI, so they have an infection, so they get septic, diabetic. Anything else? Drugs, alcohol, dehydration. Psychiatric, yep, lots of stuff. That's the one thing I wish we could change our dispatch is not to be dispatched anything called a stroke. It should just be the altered level of consciousness. Because there's really, we don't know it's a stroke. Okay, the ABPU. So the one thing about EMS and fire related things, lots of acronyms, right? So alert, verbal, painful, and unresponsive. Video. So alert, patient's awake, opens eyes. So when you walk in the room and they look up at you, they're alert. Oriented to person, place, time, and situation. Okay? How do we know, you know, this is a tough one with our, again, in our retirement communities. They might know who they are and they might know where they are. Generally, they're good with those two. But time, okay? They've been retired for 30 years. They might not know if it's Monday or Tuesday. They also might not know if it's you know, the 25th or 26th or 27th, or I don't even know that all the time. So, so what are some other ways you can assess that? How many quarters in a dollar? That's a good one. Be careful of their birthday. If you're asking them, make sure you know what their birthday is. So have their driver's license or something with their birthday on the pulse form. Have something with their birth date on it, because you say, Chris, what's your birthday? He rattles something off like that. Well, sounds good. But he's 88. He just gave me his wife's birthday. You know, but okay, if you don't have that, then you don't really have anything to check it to. The president questions are always interesting. Make sure they give you the name, though. Make sure they give you the name. They can't say that dirty, rotten, whoever. Okay? Right. Yeah. So I like the third one. Organized, coherent answers to questions. So the 4 quarters in a dollar. The bottom one, we get the pediatrics, quiet child, usually seriously injured or ill. Okay, so they're alert to verbal now. So they're not, we walk in, they appear to be unresponsive. This is my patient he became this way last night. They look like they're sleeping, but they respond when you talk to them. So they're responsive to verbal stimuli, or they'll at least open their eyes. So we want to make sure we note that. Infants might have to shout at them. This chair's in my way. Pain. So we try to elicit a pain response. They might wake up, they might talk to you, they might at least just moan and groan, they might move, open their eyes, something. So the IVs start. You poke that patient with the needle, and most people, if they don't know that's coming and they have some level of responsiveness, are going to at least see, you'll see something. They might not pull their arm away, you'll at least see a little movement of some kind. Sternal rubs, the trap pinch, there's all kinds of different ones that elicit pain response. Pinching between the fingers, anything that's going to be, it's kind of like training your dog. I got hunting dogs, kind of like training those things. A little pinch on the ear, it hurts, but it's not harmful. So something you want. The sternal rub, that's one to be a little bit careful on. But find some way. I watched an ER doctor put what are the clamps, little scissor clampy things? What's that? Yeah, something like that. Took a guy who he thought was drunk, and I think they were, into the ER. He clamped. No, it was like the little scissor thing with the clamp. Clamped it on his nipple, and turned it in circles. And it never did elicit a response. So, yeah. Okay. Decorticate or decerabate, what's the difference? Core. Yeah. So I still got a chance. I have no chance. Yeah. Yeah, serious brain injury. So, but that's how I remember. I don't know if that's true what I just said there, but that's how I remember which was worse. Is this was I still have a chance, and this is I have no chance. So that's how I split those up. Unresponsive. So they don't respond to anything. So if you didn't know this already, it's probably a different class for you. So, but this is the big one here. If we have no response, completely unresponsive, this has got to become, this doesn't mean they need to be intubated. I'm not saying that. But we have to make sure this is in our mind. We got to protect the airway. If that was the case, everybody that was passed out drunk would get a tube, right? Yeah. We need the numbers. So, patient's responsive, it can speak clearly, we can assume they have a open and patent airway, like right now. Every one of us has an open and patent airway. This really comes into play when you go to do this, when you walk in and you do your BSIC, say if I have a single patient, I don't need C-spine, I want an additional crew, and then hi, I'm Dave, I'm with EMS, and the patient responds, and then you would say, okay, the patient responded to me, I know they have an open and patent airway. So that's where that comes into play. And that's what we do. And that's the thing about this sheet, is this top part of it, you can knock out in like 3 sentences. But this is what makes this top part of the sheet difficult, is this is everything that you see. You're not doing anything. This is in the real life world. This is what you see, everything we just talked about. When you walk in the room and you see the person and they look up at you, you know they're alert. You look at him and you see, I can see he's at least pretending to listen to me. So he's listening to me right now. I know that. I can see he's alert, he's looking at me. But we see that in patients. But when we go to do these assessments, we have to say what we see. We do what we do, we have to say what we see. And that's what makes it difficult. We don't have a hard time with it because, yeah, we walk in and we see the patient and they give us some kind of communication non-verbally back, but that's, you know. Okay. So patient's unconscious, airway may be obstructed, so that's why we want to get that airway open. How do we know if the airways might be partially or completely obstructed? What are some clues? Lung sound, what's that? You're pointing at. You can hear him wheezing. Yeah, usually when you hear him breathing or snoring, snoring is a good indication.
You don't see their chest.
Yeah, you don't see any chest rise. So we assume they have no gag reflex. They cannot protect their airway. Have that suction ready. Does suction go in on every call? Let's be honest. No, it doesn't. No. And that's something else. Again, we'll sidebar here a little bit. Suction doesn't come in on every call. So something to keep in mind. Something else that, at least in my agency, doesn't come in on every call when we're talking about airway, and that's RSI medications. Some of them stay locked up in the rig. Our sedatives stay locked up. So when you're doing so you have to think about that, because when I'm sitting in your seat and you're doing a scenario, you can go, oh, I want an RSI medication. Boom, it gets done. Well, in reality, there's a reason why Spokane County changed RSI and took the rapid out of it, because it's not rapid. Been an RSI call, right? It take a while. Unless you kind of think it's going to be an RSI, for us, we bring our little Tupperware thing in locked drugs. I don't know how everyone else does it. I know that AMR, the drugs are locked up. I don't know if City Fire, I think they're in the box, and they're in the box. But again, that's one of those things. If you don't have the stuff with you, you always have in the back of your mind, what's your strategy to get them? I've worked with Christine on lots of calls, but I don't know that I can say, hey, go get my RSI drugs. You even know where they're at. No. And she doesn't know the combination either. So there's that to go into. That's the other part of it. If I'm working in, City Fire, District 8's box, do I know where everything is? That's the other things to kind of keep in mind. Lots to think about as a paramedic other than just IV tubes. There's a whole lot of all those little things that always come back to you that you have to keep in mind. When that call goes south, everyone's going to be looking at you. The BLS guys will be talking behind your back. The truck guys are going to be, well, they don't care, they're truck guys. If you suspect C-spine, open airway using a jaw thrust without extending the head, head tilt, chin lift for everybody else. That's just showing jaw thrust maneuver. Probably picture right out of the book, and there's the head tilt. So assess airway, we're looking for chest rise while you listen and feel for air movement. Noisy airway, partially obstructed. Gurgling indicates fluid. Snoring indicates what? Tongue. Okay, stridor. We're going to talk about all these different lung sounds here later on. Stridor is caused by an upper airway obstruction. And what makes that stridorous sound usually? Inspiration or expiration? Expiration. If they got foreign body obstruction, abdominal thrust, if they go unresponsive, then we go to CPR. So this is all right through the door. So you walk through the door, and you see a patient's unresponsive, and their airway is compromised. This is all the stuff going right through the door. We really can't do CPAP if they're unresponsive, though, right? The airway could be obstructed, or if we have an airway issue, we might want to use CPAP, but we're not if they're unresponsive. Does anybody here use BiPAP? Kootenai, BiPAP? No? No BiPAPs? Hospitals use it, right? Does anyone put CPAP on themselves? You have? How was it?
It's like sticking your head out.
Really?
Hard and-
We were talking about that yesterday. Tyson was daring me to put it on. That's great.
You don't even have to think about it, you just open up.
So, so notice something here. CPAP, intubation, right? Okay. So, moral of the story here. Keep this in mind. You learn one thing today. The CPAP is a ventilation tool. It's not an oxygenation tool. It's for ventilation. It's not for oxygenation. So that patient's SATs are okay, but they're tiring. Take CPAP, okay? That's going to help. If their SATs are real bad, this might help them ventilate, but that doesn't mean their oxygen is going to necessarily come jumping right up. It will probably come up. What does the CPAP deliver for oxygen? It's not 100%. It's down like about 30. Yeah. And if you, I had a CPAP call go south, so I did a bunch of research on it, because I was blaming the CPAP, and I think I just need to blame it, because I don't think I recognize things quick enough. One thing I read on it is if you take that hose, the dryer hose, whatever you call it, it's like a dryer, and you extend it out, you're lessening the oxygen delivery.
Really?
Yeah, I don't understand how or why necessarily, but you stretch it out, and you're drawing more air in. You're still above 21% or whatever we're getting out of the room air, but it's not like we don't think, oh, it's 100%, right? You're hooking it up and it sucks your tank dry. So you think, well, we must really be delivering a bunch of oxygen. It might be higher than 30, but it's not as high as we think. So remember, it's a ventilation tool, not an oxygenation tool. Because if you look at them, they do have a port with supplemental oxygen. So, yeah. So anyway, keep that in mind. What's not on there if they don't have? What's another ventilation tool they don't have on there? BVM, yeah. Where's the BVM? If you do BVM somebody, two-person, at least two people. If they are, again, airway assessment, be looking out for these things. Anaphylaxis. I had an allergic reaction, not anaphylaxis last night. Allergic reaction, a Shopko employee, 17-year-old kid helping someone in furniture, and all of a sudden broke out. And he was stuffed up. He was congested. His nasal passages were 0. He was shut way down. And he was hives all over, and he was waiting for his mom to get there, so he wasn't really having any trouble breathing other than through his nose. By the time his mom got there, he was good. It was funny. His skin went from pink to white. So, yeah, weird. So wheezing caused by constriction of the smaller lower airways. So these people we want to be thinking about are albuterols or duonebs. If patient's not moving air, bad day. They're in respiratory arrest. So provide ventilation with bag valve mask, high flow oxygen. We can tube them if they're unconscious and lack a gag reflex. Be careful of that one without going through the full RSI procedure. You take like our heroin overdose. Okay, try Narcan. Narcan doesn't work. So we tube them. And we tube them without RSI medication, okay? Because they have no gag reflex. Guess what? The tube goes right in because they're in their 20s and they're always skinny and thin, so they're easy to intubate. And we don't put RSI drugs on board. Then guess what happens? That Narcan starts to kick in a little bit, or the drug's wearing off, and then what's going to happen to that patient? They start moving around. They're going to start fighting. And what's in the way? Yeah, the tube. Yep. And then they're going to try to self-extubate, and that's ugly. So keep that in mind. Dr. Edminster, he always like to say, just he was always joking. I think it's kind of a joke. Tube those patients because they've taken care of their own, they've sedated themselves. So tube them versus Narcan, because Narcan you just create a problem. You're going to throw up in Christina's ambulance, or yeah. So there's a 2-person BVM. Very effective. So when you're in your labs, maybe not today, you won't have an opportunity, but sometime in the next few months, do it. Try to do 1-person BVM and then just do a 2-person BVM. If there's 2 of you, so if you're on engine 85, 2 of you, or AMR shows up first, and you have to do CPR, you can have that person just hold the mask in place, and then you do your compression, your 32, and you just reach up and back. So unless one person just holds that seal, that's all they're doing is pulling that face into the mask the whole time. I guess we don't have to bag on it. We can put the non-rebreather on. There's the OPA, getting the tongue out of the way. The NPA, one of my favorite tools. Don't be afraid to use those. It's designed to go down the right nostril, but you can put it down the left one too. So one's good, two's better. So you can use it. I figured out another way you can determine proper length is when you go to innovate. If they have an NPA in, you will see it. You'll see it. You'll see it down the back. Yep. I found that out on accident. I saw it back there. I'm like, what is that? There's something in there. Something green. Oh yeah, it's the NPA.
Is that a good thing to leave in during intubation?
You can leave it in, but if it's, I had them pull it out because it was distracting. Yeah. Okay, so again, if they can't, no gag reflex, cannot protect their own airway, and we're gonna go. We got our endotracheal tube, multi-lumen airways like things like King's, combi tubes. What's the one we have? iGel, which is like it's an LMA. And if they're just showing airway and signs of hypoxia, we've got the non-rebreather mask. Back to the CPAP thing. I know we have our CPAP around here. They say that stands for COPD, pulmonary edema, asthma, and pneumonia. But it works best on pulmonary edema. So you have those people that are tight with COPD. I'd like to give them a chance with non-rebreather and albuterol or doing it first before going to that. It seems like a lot of people are, the CPAP is scary, I guess. So they're not very compliant with it. They want to pull it off, which is another sign that maybe they don't need the CPAP. Because I don't know what your guys' experience is, and you put someone on CPAP and it's helping, what do? They'll hold it on their face. But if they're pulling it away, CPAP's probably not meant for them. The other thing with CPAP, my experience is when it works right now. It's not like, well, let's wait and see if it works. It's like it goes on and you can tell that patient goes like almost, yes, thank you. But if it's like, well, let's give it another couple of minutes, then you probably better get your other stuff ready because that's where they're going to go. All right. So breathing. So how do we assess breathing? If they're altered, confused, agitated, that was my patient, my tripoding model patient. Shortness of breath while speaking. Another one that you said you go in their difficulty breathing and they're smoking a cigarette. The other one is they're short of breath or difficulty breathing and they're speaking longer sentences and faster than I am right now. Okay, this doesn't seem right either. Retractions. So when you see the skin drawing in. You ever seen it before? Ever seen retractions? It's kind of creepy. Asymmetric chest wall movement or accessory muscle use. So it really looks like they're the best way I think accessory muscle use. They really look like they're really working at it. But all bad signs. Audible sounds. I left cyanosis out for a reason. We'll come back to that. Audible sounds. So what are some of our audible sounds we might hear? Let's just talk about all lung sounds in general. We're gonna steal some thunder from a little bit later on here. What are some of our lung sounds? We may audible or not. So audible means you can hear them right now versus auscultated. What are some of them? Okay, so you just rattled off 3 of them. So stridor is upper airway, wheezes, small lower airway on, what's that? Exhalation. What was the third one? Is it?
Bronchi.
What's Ronchi?
Fluid in the lungs.
Wet. Yeah.
Chunky urban.
Okay. What else we got? What's another one here? You go get stridor, wheezes, Ronchi.
Choking.
What's that?
Just choking.
Choking.
Yeah.
Choking. Okay.
Coughing.
I'll give it to you. Coughing. Another lung sound.
Crackles.
What's that?
Crackles.
Crackles. What are crackles?
They're in the alveoli sacs. Wetness.
Wetness. Okay, so fluid, right? So rails, wheezes, stridor, crackles.
Gurgling.
There's a fancy name for another junky one.
Rounds.
Rowels or rails, yeah. That's more fluid, right? And then we said Ronchi already, right? Lack of sounds. That's a bad one. Yep, absent. So they're or diminished. They're trying to breathe in. They're making the motion. You're not hearing anything.
What's the pleura when it separates?
Oh, the pleural rub.
Yeah.
Sounds like if you rub your fingers on a balloon.
Sounds like that.
Now it does. Yeah. Here's the thing about lung sounds. I don't know that any of us. I know I'm not great. I'm not great with lung sounds. But do this. Just be honest with what you hear. You don't want to be the one that says, "Oh yeah, they're clear in all fields," and then you find out later on while the other guy's doing his assessment that the patient's missing the lower part of their lung because of lung cancer. So they're not clear in all fields. Obviously, you didn't the missing part of it. So be careful. Just say what you hear, and don't be afraid of a second opinion. Hand your stethoscope, or have another medic get a stethoscope, or an AL or a BLS person. It doesn't matter. Have someone else listen. And then the other part of that, when you go to the hospital, because we have all these different ones that indicate fluid in the lungs, all that, just tell the doctor what you hear. And I always tell them in normal terms. They sound really wet. They sound really junky. Everyone knows what that means. The doctor knows what that means. They're not gonna hammer on you for it. Use a big fancy medical term wrong, then they will. So that's why I just stick with. And the patient's lungs are really wet. They sound wet, or they sound really tight, or whatever. Just describe it in normal, plain English, kind of like talking on the radio. Okay, assessing respiratory rate and quality. So what is rate is 12 to 20, right? I think there's new books out there that are saying 12 to 24 is normal. And then how do we describe quality of respirations? Depth. So they shallow, deep, rate and rhythm. So regular and irregular. So there's respiratory rate. Ooh. That's a tough one to remember all that. I punted on that one. I knew what adult was and was going to guess. Like on a test question. When it's pediatric tests, but like the registry test when you got to know all that stuff, like, well, if I got it, I got it. I'm not going to spend extra time trying to pound that into my head. This is where reference sheets come into play. When I was in your guys' shoes, I worked with a medic who was one of Valley Fire's very first paramedics in the first class. And we had a kid, I'd show up from medic school. It's a true story. This is not made up. I just showed up to Station 1 from this, well, not this class, that class, this is this class. And walk in the station, and there's a tour going on. All these little guys. And they're doing the customary tour thing where you look at one side of the engine, and you look at the other side, and you let them get up and go sit in the seat. Put the new guy's helmet on, and then put their license helmet. Then they jump out the other side, right? Well, a kid, of course, jumping out the other side takes a face plant, getting out of the engine. So the teacher or whoever, babysitter, brings him into station crying. And there's Terry, the old paramedic. And I just got there from class. So he says, "Hey, I want you to help me with this kid." So I take all his vital signs. And I tell Terry, okay, his pulse is this, his respirating or whatever. Terry goes, "Okay, that seems normal." Okay, and then he reaches in his pocket, pulls out, the little blue spiral bound top EMS little pocket guide. He had it dog ear on the chart that had pediatric vital signs, flips it open. How old is that kid? And tell him, he's like, yep, he's fine. So, the vital signs were fine anyway. Wow, this guy's a medic. Years using a flip chart. Okay, I can use a flip chart too then. Next part of that, we take the kid to Sacred Heart, a pediatric, the PZR. Same thing. In my mind, these people that work in PZR are like dogma. They work in PZR. Kids scare all of us right now. It's like little kid patients. And I went in and do something, and here the nurse pulls out of her pocket a little flip chart and looks at something. And I said, hey, can I have that? And she said, absolutely not. We hold on to these, but she did find me one. But yeah, okay, there's number 2. They use a flip chart. So don't be afraid. Now, you can't do all your paramedicine by a reference sheet, but don't be afraid to use them for some things. And the other thing too with some of this is, remember they always tell you to treat the patient, not the number or the monitor or whatever, and that's where this comes into play. Another reason why capnography is so awesome. What's normal capnography for an adult? What is it for a 6-year-old? 35 to 45. What's a blood pressure for a 6-year-old? What about for a 96-year-old? What's normal? But their CO2 is 35 to 45. So it's a great way to measure perfusion. So rapid respirations, tachypnic. Deep, I've never heard that term before. Hyperypnic, can't even say it. So this is just all those fancy terms for the different respirations. And again, when you're explaining those to what you saw and seeing to the doctor, you're going, Biots or Shane Stokes? What was it? Just describe it. Patients take a deep, rapid breathing. Assess neck, chest before moving on to circulation. So we're looking at all this breathing, and in reality, this is all kind of going on at the same time. And we're going to correct all our life threats before we go to the next thing. So obviously, if the patient's airway is not open, we got to open it. And if they're not ventilating, we got to ventilate them. And if they're not breathing adequately, we're going to give them oxygen. So, which generally those two things kind of run hand in hand before we get to circulation. There's our friend the CPAP. Tension pneumo. So immediately decompress the affected side of the large IV catheter or the purpose-made needle, which some of us may have, the 14-gauge needle. Second intercostal space, mid-clavicular line. You guys done that one yet? You haven't got to that one yet? Okay. How are you going to assess, how are you going to find a tension pneumo? What do you have to do to find that? Have to listen, yeah. Yeah, so when you're assessing airway and breathing, and again, unless you walk in with a stethoscope around your neck, you may not get lung sounds right away. Circulation, pulse and skin. Now, I'll teach this, and I normally practice it, but when you first address that patient and walk up to them, I learned this from just for take Jeff Wainwright. I watched him do this when I was brand new. And he walked up and talked to this lady, and when he walked up to her, he grabbed her by the wrist. One side. And look at what you can get with that. You can get a radial pulse. You're not counting a pulse, but you can feel a pulse. So what can you tell just by feeling a pulse? You can feel if it's strong or weak, fast or slow, regular or irregular. At least feel that much. That tells you a lot. I can tell you a lot, right? What else can you do by doing that? What are you guaranteeing you're assessing right there with the test center? What's that?
Skin.
Their skin. Yeah, you can feel if they're warm, are they cool, are they clammy. So yeah, you can do a lot by doing that. So we're doing our circulation, obviously, we're evaluating the pulse and skin. This is more on the trauma side of things, control bleeding. So when you do the trauma assessment, like especially when you're doing the skill test out, if you walk in and someone's got major bleeding and you don't assess major bleeding, you fail. So that would be just putting your gloved hand over it. So there we are, going to the wrist, feeling for radial pulse. If it's absent, check for carotid pulse. Intent, we go to the brachial. If pulse is absent, obviously we're going to go to CPR, unless they're talking. And then we're not taking the pulse right. So The other thing, when that patient, you walk in and the patient looks at you and they speak to you, you can assume their airway's open, they're breathing, and we can also assume they have a pulse. We don't know if it's fast, slow, weak, strong. We know they have a pulse. Now remember, a pulse is actually putting your fingers on their body, and it's rate, rhythm, and quality for a pulse. A pulse is not the SpO2 probe on the finger. I know we record that on the report as their pulse, but really that is what? That's a heart rate. That's a rate. That's not, we don't know rhythm. Well, you can maybe get rhythm, but we're not getting quality. We might be able to see regular and irregular on SpO2 on the thing. So there we are getting the pulse. There's the carotid. And here's pulse rates for various ages. And again, if you're sharp enough to pack all that in your brain, then go for it. Circulation assessment, very fast, called tachycardia, obviously over 100. So for other part of circulation, we're stopping bleeding, pressure, tourniquet, all that. So some skin things. I know I left out cyanotic. So mottled, we all know what mottled skin looks like. Think of a little kid that goes outside in the cold without a shirt on and comes in, they look spotted kind of blotchy. Pale or ashen, you've probably all seen that. Clammies when they're cool and moist, and again, I left cyanotic out. By definition, cyanotic is blue, right? Kind of bluish, kind of like zombie look. Raise your hand if you know you've seen a cyanotic patient. You know you've seen it. Okay, you know you have. Raise your hand if you think you've seen one. Okay, then you haven't. You know it when you see it. That's the best way to describe cyanotic. You will know it when you see it. I haven't seen a lot. The one kid was one. He was modeled in cyanotic. I've seen a couple others, but you'll know it when you see it. You'll see lots of pale patients. You see lots of pale ones. Dead people are generally pale, not always cyanotic. But when you see a cyanotic, you know it, right? You can probably close your eyes and see it still. See what that patient looks like. Cyanotic, you will know what it looks like. Gary, cyanotic, you know it when you see it, right? Do you think you've seen cyanotic, or do you know you've seen cyanotic? Yeah, you've seen it, but there's really no, once you know what it looks like, it's, right? All right. So again, we're assessing the skin for color, temperature, and moisture. And then this is just going right down the skill sheet. The serious illness or injury, we want rapid head-to-toe assessment, and we're transporting immediately. Should be doing those two things at the same time. And we should be able to do those while we're driving. Which, yeah. Okay, I'm not going to cover that one. So that's just our primary survey. That's just looking at the patient, walking in and seeing them, and quickly assessing their ABCs. So when you look at somebody, you're doing a whole bunch of stuff right there. All that last 40 minutes that I just talked like an auctioneer through, that's when you walk through and you see somebody. That's all that's going on right there. You're assessing all that. So you're really looking at a lot of different stuff. We've got one last segment to do, and with that, we're going to talk about vital signs, and then we're going to play some more 3 questions here. Just kind of puts the 2 things together. But get up, stretch your legs again. And I need to look at that more. So much.